I wanted to talk today about post-transplant bendamustine. So it's a quite new technology, and it is applied for patients with refractory acute myeloid leukemia, AML. So the refractory AML was a disaster for hematologists for a very long time because the survival on chemotherapy is very poor, and the history of transplant of refractory AML was not very encouraging. So starting with Donald Thomas results when he had 5%, afterwards with improvement of supportive care there was 20%. The recent studies, they show 30%, but still there's 50 to 60% of relapses after the transplant, and the rest is the possibility for survival and non-relapse mortality. So the approaches that were used generally in this field is intensification of the conditioning, or some forms of sequential conditioning like Flamza-like regimens. However, with certain improvements in non-relapse mortality, these sequential regimens didn't show the improvement for truly refractory AML, which is the failure of at least 2 induction courses. And so generally the results by, for example, CIBMTR mega database show that it's 19% survival for this patient. So this is a lot of room for improvement. And we have conducted a study where we substituted cyclophosphamide, which is the regimen developed by Leo Luzhnik in Baltimore, with the bendamustine. It's another agent, somewhat similar to cyclophosphamide, but somewhat different. And its use in transplant was first developed in the University of Arizona by Manuel Cassani's group, and afterwards they published the in vitro studies, mouse studies, and they show that this agent spares very much the stem cells, but induces some form of tolerance. And they tried to conduct a clinical study, but the enrollment was very poor, and they didn't tried to do the bendamustine as a single agent, but rather use the combination of cyclophosphamide and bendamustine. In our university at St. Petersburg, we developed a study where the target population was refractory acute leukemia, because these patients have very poor prognosis otherwise, and so if something went wrong, we didn't compromise the results of the transplant very much. So we first expected that it will be somewhat very similar to cyclophosphamide, with just improvement in the pace of engraftment. However, what we've seen from the first patients is that it is a completely different thing, because even from the first patients, we have seen that it induces some form of macrophage activation syndrome almost in all patients, at least when it's used as a single agent. When it's used in combination with the immunosuppressives, the rate of this macrophage activation syndrome is lower. So in other terms, it's called cytokine release syndrome. And we have observed the syndrome in the majority of patients with various clinical presentation according to HLA compatibility. So in fully matched donors, the rate was around 40%. In haploidentical donors, more than 80% of patients had this CRS. And I think induction of this particular phenomenon was the underlying cause that we have seen almost more more than 90% complete remission rate with this regimen, and more than 60% of molecular CRs after the transplant, compared to 75%, for example, for Flamza-like regimens for other myeloablative conditioning. We observed particularly good results for acute myeloid leukemia. So there was no long-term effect for acute lymphoblastic leukemia, but for acute myeloid leukemia, at least in the middle group, we have seen 44% survival. And this was a de-escalation study, so we started from the high dose of bendamustine, then we went lower, and without doubt that the middle group of 100 milligrams per square meter is the optimal dose. So this is almost the results of the completed study so far, and we hope to present the final results at ASH this year, and want to start the multi-center trial in Russia to evaluate the reproducibility of this regimen in refractory AML.